Tonight we are blessed by a new, I won't say new, Dr. Paul White has been here since 2018. I'm going to read his quick bio here. Dr. Paul White, born in Spokane, we can't hold that against you.
Yeah. It's not California.
You have no choice where you're born, but you do where you live. So, the grandson of a small-time GP in Newport, Washington. After college at the University of Washington, he moved to Belfast, Northern Ireland, to do volunteer work. There he met his future wife and decided to stay and study medicine at the National University College Cork. He returned to the U.S. to do his residency in Cleveland, Ohio, and his oncology training in Boston. Dr. White joined Kootenai Cancer Center in 2018. So we are honored tonight to have a new, young, he's got good, fresh ideas. You'll like him. I like him. I even told him when we met that he might be my new doctor now that Mobley retired.
Don't threaten me.
Somebody's got to put up with me. So
Wait till after this.
Anyway, I want to introduce Dr. Paul White.
Thank you, Jim, for inviting me. And I've put together this fantastically amateur slideshow. And I will start it off by saying that you said in a couple weeks you're going to get in a circle and you're going to cry and cuss and throw chairs. Cussing at the wind is pretty therapeutic. And when I was a kid, I was in a class, and my teacher, somebody had gotten upset in the class, and he said, "You're upset. Sit down, take a sheet of paper, and just write all the dirty words you know." And for a second or third grader, that was dangerous. I had my mouth washed out with soap before. But it's a powerful and therapeutic technique. So go ahead and cuss under your breath. And so when Jim and I were talking, and he had asked me to come and do this talk, I wasn't sure what I wanted to talk about. There are so many topics and so many things involved in cancer treatment and going through chemo and immunotherapy and the different stages and caregiving. But I thought it might be interesting to talk about where drugs come from and how do they get developed and why we use what we use. And so you already did this part. Just to say, I do have two young kids, Alex and Connor, and they're 6 and 9. Alex was born when I was in Cleveland, the year the Seattle Seahawks won the Super Bowl. And then Connor was born in Boston, and then we brought them both here. And always wanted to get back to the Northwest, so here we are. I want to go back to the very beginning, to World War I. And if you can imagine being in the trenches in France and Germany, and all of a sudden going blind after you smelled something funny, they used nitrogen or mustard gas. And mustard gas was, unfortunately, a common weapon in World War I, and it didn't really kill people. It maimed them, it made them blind, often very, very sick for the rest of their lives. But one of the side effects that they found was that the white blood cells of mustard gas victims fell dramatically. And they tried to use that in diseases of white blood cells, notably lymphoma, and found tremendous success. And that is a common theme in cancer medicine. We use poison to kill cancer. And so chemotherapy at its very heart is poisonous. And the other important thing to remember is that cancer is us. These are cells that are part of our body, and they still are, but they're different somehow. And they're misbehaving, they're acting at cross purposes with us. But trying to find a way to kill something that is us without the good part of us getting damaged is quite difficult. And so we found that this stuff called nitrogen mustard was good at killing white blood cells. And so they tweaked it. And we now have many different medicines related to nitrogen mustard that work to kill cancer. And we still use these medicines today. A lot of these might be familiar to you. And so we've got all these poisons that work by attaching to DNA and preventing a cell from replicating. One cell becoming two, and two becoming four. And it blocks that process of DNA replication. And so some clever people discovered that, yes, indeed, DNA replication needs resources, needs nourishment, needs vitamins and minerals. And if we can block some of these things, we can prevent cells, cancer cells, from replicating. And so we have another class of medicine called antimetabolites. And what they do is they mimic or they act as DNA molecules, and then they get incorporated into that replicating DNA, and they block the cell from finishing that process successfully and kill it. Or they take something like folic acid, for instance, and they block the cell from using folic acid to replicate its DNA and kill cancer cells that way. And the list, I'm sorry it's so small, of different chemotherapy medicines that we use that follow this strategy is huge. And all of these we still use. We use them for all kinds of different cancers, leukemias and colon cancer and breast cancer and lung cancer. These are used in all kinds because they all do the same thing. They all reproduce and replicate faster than the rest of us, the rest of our body. And so there's still a role for these poisons in treating cancer. In the 40s and in the 50s and in the 60s, there was a new strategy. And that was that we noticed that some organisms have the ability to create chemicals that kill other organisms. And we thought, if this works to kill bacteria, for instance, can it be used to kill cancer? Lately, ivermectin has been really popular. And there's a reason for that. And I'll get to that in a moment. But the first process here was finding an antibiotic that killed different bacteria called actinomycin D. And they did clinical trials and found that at really, 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 really high doses, by golly, they could kill cancer. But they made people very, very sick. But it proved a point that some antibiotics can kill cancer. And so we found a whole class of antibiotics or anti-cancer medicines that came out of actinomycin D. Doxorubicin or adriamycin is common in the treatment of breast cancer. Daunorubicin and idarubicin we use to treat leukemia and different sarcomas. And so we have a lot of benefit from these bacteria giving us other antibiotics. Now, we have trees that give these toxins that prevent infections, all the taxanes, paclitaxel and docetaxel were found from the Pacific yew tree. We have topoisomerase inhibitors, etoposide, topotecan, which were identified in the May apple tree. And the vinca alkaloids, vincristine and blastine, which we use in leukemias and lymphomas, in the Madagascar periwinkle. And this was something that was done decades ago, looking at all kinds of compounds that we had identified and purified and synthesized in the lab to say, okay, is this going to cure cancer? does it kill a cancer cell? And so a lot of good, helpful cancer medicines come from plants and also are used as antibiotics as well. And so something like ivermectin, for instance, which has been in the news a lot lately, it's quite natural to go, hey, I wonder if this will help. And I can honestly say to you, it's been studied. It won't help your cancer. It's a great dewormer, but it's not for this. And so that's what I'm going to talk about at the end is the clinical trial process and how do we find out if something's going to be helpful and effective and tolerated, which are the big three things that we want to find in a medicine that's going to treat cancer. And here's the Streptomyces bacteria, the Mayapple tree, the Pacific yew. This one's the Madagascar periwinkle and the Mayapple tree. And all this work was done decades and decades ago. And we've identified all these chemotherapies that I've talked to you about a long time ago. And for a long period of time, there weren't that many advances in the development of new chemotherapy drugs. And the focus was really on, okay, what's good at treating what kind of cancer? Because there are all kinds of medicines that are great for colon cancer that aren't going to touch breast cancer, for instance, or leukemia or lymphoma. So there was this period of trying to identify what works where. And how do we administer it? Do we give this before surgery or after surgery? Do we give this, what's safe to give with radiation? What's safe to give intrathecally, meaning in the fluid around the brain? Sometimes we'll do something called a lumbar puncture where we can deliver chemotherapy into the fluid around the brain and down the spinal cord. And some medicines are safe to do that with, and some medicines are deadly to do that with. And so these were all questions that were being asked in the 60s and in the 70s and in the 80s and the 90s. But victories became slower, and we made fantastic advances, but those advances, there was a diminishing returns on these medicines. And so it took a new set of skills, a new way of thinking to try and find another way of targeting cancer and how best to treat it. And so we come to what is now the era of targeted medicine, where, or another way of saying that is personalized medicine. Not all cancers are equal. Even lung cancers, we know not all lung cancers are equal. And not all breast cancers are equal. And so in the 1980s, some very smart scientists identified something called the HER2 protein. And HER2 is found on many breast cancers. And once we recognized it, we realized that women with HER2 positive breast cancer had a much more aggressive and dangerous and deadly form of cancer than those who didn't oftentimes. Well, we didn't know how to treat that. And somebody found a way to develop an antibody to that protein. And what they did was they took HER2 and they put it in a mouse. And the mouse, their immune system recognized, I don't know what this is. This isn't part of me. And they attacked that, which is a natural response to a foreign protein. And they developed a way of extracting antibodies from that mouse and turning it into something new that they could then give to a human without causing that same reaction. And in doing so, would attach to that HER2 protein and cause that breast cancer cell with the HER2 on its surface to be destroyed. And this was the first monoclonal antibody. And that's another term I'm sure you've heard a lot of, because it was first done here in the treatment of breast cancer. And so they tried it in a test tube, and it worked. It killed cells immediately. And then they tried it in animals. They would give mice, for instance, this breast cancer with the HER2 on it, and it would develop tumors very quickly. And they give this Herceptin or trastuzumab to the mouse, and those tumors would shrink dramatically. Again, very, very quickly. And so before they could ever give it to a human being, they had to assess its effectiveness in the test tube and in an animal. And so for the first time in 1992, the first group of women got Herceptin. And of the first 15 or so women who got it, about half had remarkable responses. And the other half did not, and they were withdrawn from the trial. But it showed that this approach could be very effective. And so they made more of that drug, and they brought it to another clinical trial, a larger one. And today we use it in a tremendous number of women, even still, 30 years later. The next discovery was that proteins have a very specific structure. And I'm going to put this up first. This is a protein called the BCR-ABL. And a protein is made up of a string of amino acids. But it's not just a string. That string is arranged in this very complex structure of coils and bends and turns. And if the protein is not in the correct configuration, it doesn't work. And so that's the next approach that these very smart scientists took, was to try and lock or change the structure of proteins. So BCR-ABL is a fusion of two proteins that come together in chronic myeloid leukemia, CML. It's the product of two chromosomes that end up getting stuck together, chromosome 9 and chromosome 22. And when these two chromosomes get stuck together, they create this, and this is a light switch for the bone marrow that gets stuck in the on position. And it causes our bone marrow to just churn out white blood cells way, way, way too fast. And so if you look on that picture, you'll see a green splotch. And that green splotch is a molecule called imatinib, Gleevec. And Gleevec is just a lock that fits in this keyhole and stops that from doing the job that it's trying to do. And it's able to turn off that light switch. And so this is the next approach that we've seen a tremendous number of medicines come out of. The tyrosine kinase inhibitors. And these are just molecules that fit in a lock and stop the protein from doing the thing that it wants to do. And if you take that green splotch, sometimes CML figures out a way around it. And that's another thing about cancer. It always seems to have this sneaky ability to figure out a way around the treatment that we want to use. And so what we do is we take that green splotch and we change it just very slightly. And imatinib becomes nilotinib, or pazopanib, or any number of the BCR-ABL tyrosine kinase inhibitors that we have available. And those are a huge number of treatments that we have for all kinds of diseases. There's so much cool stuff. In 2022, there were about 40 new FDA approvals for either old medicines for new indications or entirely new medicines that have cool new approaches for working. One of the medicines that we see most often approved now for new indications are checkpoint inhibitors or immunotherapy. And immunotherapy has, in my opinion, been one of the most exciting ways of treating cancer that's come around since I've been in practice. And I can remember the first patient I treated with nivolumab when I was still in my residency. And it was still very new and experimental. And it was first the CTLA-4 inhibitor, or ipilimumab, or Yervoy, was first introduced and treated melanoma. And metastatic melanoma is very responsive to immunotherapy. And the way that it works, let's see here. Oh, I didn't put in a picture for this one. But what it does is cancer hides. Cancer hides from our immune system. And our immune system would love to attack it, but cancer has this funny way of deactivating our immune system and camouflaging itself so that it can't be attacked. And so the checkpoint inhibitors, ipilimumab, nivolumab, pembrolizumab, take off the camouflage of cancer. And at the same time, they turn on the immune system and rev it up so that the immune system can recognize and attack the cancer. Again, there's this paradox, though, of trying to attack cancer, which is us, and to not attack us, the good part of us. And so the side effects of these immune therapies
can be to turn
recognizes
on
and attacks
autoimmune
our
conditions.
good, healthy, normal, where our tissues, like our
healthy
lung,
and normal immune
and our
system
liver, and our colon, and our
recognizes and
skin.
attacks our good, healthy,
And
normal
so there's no
tissues,
perfect
like our
medicine
lungs,
yet
and our
to be
liver,
found.
and our colon, and our skin.
These are cool
And so
compounds called
there's no
antibody
perfect
drug
medicine yet to
conjugates.
be found.
And if chemotherapy is a shotgun, then these are a rifle. And when I say that, I mean that it is a combination of the monoclonal antibody attached to a tiny little molecule of chemotherapy. And if you have a target, so for instance, we use these in breast cancer as well, with the HER2 protein, where you'll have a monoclonal antibody to HER2, and it is attached to a tiny little chemo molecule. And when it attaches to HER2, that chemo molecule gets ingested into the breast cancer cell and destroys it from the inside. So you're not delivering chemotherapy everywhere, you're delivering it to just the target cells that have that protein on them. Another one that we have now is called a bispecific T-cell engager. And what this is if you took the clingy parts of an antibody, one to the cancer cell that you're interested in, and the other to a good, healthy white blood cell, what you can do is direct a destructive T-cell to the cancer cell and stick them right together. And it's a really exciting way of treating certain kinds of lymphomas or multiple myeloma. Another one that I didn't put up here is something called a CAR T cell. Have any of you heard of CAR T cells? CAR T cells are when you take out a whole bunch of white blood cells, and then you engineer those white blood cells to recognize just a certain part, a certain little segment of the cancer cell. For instance, again, lymphoma and multiple myeloma are the two commonest that we use, although they're developing others. And then you give those white blood cells back with a new mission of just seeking out and destroying the cancer cells. And so those are not available here in Coeur d'Alene. You have to go to someplace like Seattle or Portland or Salt Lake City to oftentimes a bone marrow transplant center where they can deliver these really new and exciting medicines. One day I hope to be able to deliver those here. And I look forward to that day. Not tomorrow. Not the next day. So just real quick, I want to talk about how do we get medicines to the patient? Because we've got all kinds of chemicals. And we want to make sure that the chemicals we're using are effective in cancer. And we want to make sure that those chemicals are as safe as can be. And so first comes preclinical work. And this is the test tube stuff, where we deliver a medicine to a cancer in a controlled lab setting. And we see what happens. Do we need to add white blood cells to the mix? Do we need to add certain nutrients to the mix? Can we make it work in certain conditions where we see destruction of cancer cells? And if we do that, then we move to an animal, to a mouse, and we give a mouse cancer.
And that's unpalatable to a lot of people. We owe a tremendous debt of gratitude to lab animals, because without them, we would not have a safe way of testing medicines for us. And so it is not likely that I talk about this, because they give a lot for us. And if we find that animal studies show promise, then we can move on to a phase 1 clinical trial. And the first time we give a medicine to a human being, it's called first in man. And this is usually, not always, usually done for healthy volunteers. Because they're fit. They've got good, strong heart and good, strong kidneys. And we want to know, are these people going to tolerate this medicine? Now, this is true more so for other kinds of medicines, not so much cancer medicines. Cancer medicines are toxic by default. We want them to harm tissue in some kind of way. And so to a certain extent, it would be unethical to give that to a healthy person. And so for cancer medicines, generally they're with the kind of cancer that we're in the patient that we're trying to treat. And so what we're looking for in a phase 1 clinical trial in a very small number of people is how much can we give? Because we don't know. When we give it to an animal, it's very, very different. And so we start off at a very, very low dose. And we give them a little bit more. And then we give them a little bit more. And we find out what is the maximum tolerated dose. And 2, does it do any good? When we give it to this person, does it do any good? Has it helped their tumor shrink? Has it helped them feel any better? Has it helped in any measurable way? And if it's achieved both of those, it's tolerable and it's effective, it goes on to a phase 2 trial. And this is where we do a slightly bigger group. And we have an idea about what dose we can use. And we're doing scans, and we're doing lots of blood work to see how things are going, and we're measuring toxicity, lots of side effects. How is it affecting you? How is it making you feel? Does it shrink the tumor? And if it's achieving all of those goals, then it can move on to a phase 3 clinical trial. A phase 3 clinical trial is the big one, and this is the big test, because we've got tons of medicines to treat tons of kinds of cancer. And what we want to know is, A, is it any good, but B, is it as good as what we got now? Because we've got all kinds of medicines. I might not want it if it doesn't do as well as the medicines we've got, as the standard of care. And so generally, phase 3 clinical trials are a comparison of the new medicine versus the comparator, the standard of care that we already have. And we want to make sure that if we're going to move forward with the medicine, the chemotherapy, is it going to be better than what we've got? And so we do this by several different techniques. We want to know, A, is this result real? And so we try to balance both groups so we know that they're an accurate comparison. Do we have the same number of patients on both sides? Same number of males and females? Are they about the same age when you average them out? Is the stage of the cancer the same? And so we stratify the groups, the two arms, as best we can and balance them so we know that they're comparable. And then we randomize them. Before you get chosen for a clinical trial, you have to fit all kinds of criteria, and then you get put on a group. You don't know where you're going to be. Are you going to be on the new one or the old one, the standard of care? And some people would prefer to be on one versus the other. If there's a really exciting drug, lots of people are going to want to be on the new exciting drug. But we need to have somebody to compare it to. So not everybody ends up that way. Sometimes clinical trials are blinded. And what that means is
you don't know, even when you're on it, which drug you're on. And sometimes the doctor doesn't know what drug you're on. And that's called double-blinded. And those criteria, a randomized, blinded, placebo-controlled trial, is the gold standard for knowing if a medicine is going to work, how helpful it's going to be, and whether or not it's going to be approved by the FDA for use in human patients. Sometimes, in order to get the information that you want out of a clinical trial, it can take absolute years to gather the data. And that can be frustrating to wait. We want cool new stuff now. But in order to do it right, it's got to take time. This is a table that shows how drugs do in different settings, different disease groups, going through different clinical trials. So if you look in the first column of numbers, the top left, oncology is at the top, about 57% of drugs pass on from phase 1 to phase 2 clinical trials having achieved their objective. But that drops dramatically from phase 2 to phase 3, and again from phase 3 to approval. And what that means is when everything is said and done, about 3.4% of medicines go from phase 1 to FDA approval in cancer medicine, meaning we try a lot of stuff to see if it's going to work. And the fortunes of companies are made and broken on the success of clinical trials. But at the end of the day, we want to make sure it meets both of those criteria. Does it work? And is it safe? And only a small number of medicines achieve those goals. What's this all for, though? Well, this is improvement in cancer survival from the 1970s on the left to the mid-20-teens on the right. And some of these are just amazing improvements. You can see lymphoma going from, this is, I think 5-year survival, but I can't remember off the top of my head. 46 to 70%. Prostate cancer from 67 to 98%. And just tremendous improvements in cancer survival over the last several decades. And so we are reaching milestones. But when you are in the midst of it, when you are that mule being tossed on, being dumped on, moving forward can't come fast enough. And so it can be really frustrating to be a cancer patient waiting for the next thing. But it is with good purpose. And so I want to end with that we are making strides. Maybe not as fast as you want, but we're doing better every day. We've got new medicines and new techniques and new treatments all the time. And that's what we strive for every day. So I just want to thank you all for listening to me ramble on. And any questions you have, I'd be happy to take.
I have a question on your last slide.
Oh,
Was it no, you
Go for it.
It looks like uterine and cervical cancer, unfortunately, went the wrong way. Is there a reason for that, or any sort of?
So I don't know the answer to that question. And I suspect that part of it is due to increasing rates of those cancers and later diagnosis, which illustrates the importance of cervical cancer screening and the uptake of the HPV vaccine, which prevents cervical cancer. And also that, and I don't know why uterine cancer survival is worse. I'm not sure about the answer to that, in all honesty. And I don't like saying that, but it's the truth. So, what were you going to say?
Oh, why oncology? Why did you decide to go in oncology?
2 reasons. The first was sitting in a lecture hall at the University of Washington in a genetics class and learning about the genetics of cancer and being utterly fascinated. and that fascination following me, even when I wasn't interested in doing medicine. When I graduated from UW, I had no intention of going into medical school, but I was always fascinated by cancer. And so when I did go to medical school, I knew this was where I was going to end up. But the other part, and probably the more important, is that cancer medicine and oncology have really tough conversations, heavy, deep conversations. And I'm going to toot my own horn. I think I am good at those conversations, at teasing through nuance and trying to figure out what is it that you want, what are we aiming for, and how do we get there. Yeah.
Can you speak to funding for different drugs? And at least in women's cancers, we hear a lot about breast cancer, and it seems like they get to play favorites, which is good for them, of course. What can you tell us about funding for different kinds of cancers? Research.
So that is a complex question. So I got to deal with it. First of all, common cancers are common. And breast cancer is the commonest cancer among women. And so for that reason, and also it's a very visible cancer. There's a lot of people, because it's common, there are a lot of people out there advocating for it. And so they do get, it seems, an unfair share of the research money. So the Susan G. Komen Foundation, for instance, is this endowed foundation with perhaps hundreds of millions of dollars set aside for research. And so it seems unfair that is the case. Common cancers mean there's lots of patients, and lots of patients mean there's more people who are going to pay for the drug. And so drug companies are more likely to pursue a drug that's going to have lots and lots of patients to give it to. And so I think both of those are reasons why certain cancers have more action. And there are what are called orphan diseases. Have you ever heard that term? An orphan disease is one that very few people have. And so if you've got an orphan disease, and maybe we have fewer treatments for it, the bar for passing a clinical trial becomes much lower. And the reason for that is, we don't have as good a treatments, so it's easier to beat what's already there. And two, there's less research being done on it, and so when you find something that works, by golly, I'm not going to push as hard. Something about a state phase 3 clinical trial is you've got to have a ton of people on both sides. Some diseases it's just not feasible to do a phase 3 clinical trial because there's just not enough people to enroll. And so there are pluses and minuses, even though there are some diseases that get short shrift. Exciting things can happen. Awareness is a big one. Some undergrad's bright idea, and they have some success, can be a real turning point for a small disease that may not otherwise get any part of the limelight. And then they have their career made because they had some fantastic idea in that one little spark. Yeah.
To that, why do children's cancers, like out of $1, say 96 goes to adult cancers and 4 cents goes to children's cancer? Why would that be? Because there's less children's cancer in compared to the population, or?
So that is another excellent question. And the first thing I would say to that is medicines get approved in adults,
Right.
and then get transferred to children.
Okay, that makes sense.
Oftentimes.
Mm-hmm.
And so, for instance, we have ALL, acute lymphoblastic leukemia.
Mm-hmm.
And we still use the same old drugs that we did decades ago in adults and in children. But one of the medicines I talked about, the BITE antigens, so bispecific T-cell engagers. There's one in ALL called blinatumomab, Blincyto, and it was first approved in adults, but it has tremendous success in children as well with relapsed acute lymphoblastic leukemia. And so we want to make sure that they're safe in us big folks first, and then we can try them in children. Some tumors, like a Wilms tumor or neuroblastoma, only happen in children. And for those are tough. And trying to find a target, because even in some of those, the stuff that we have doesn't work, or is, again, quite toxic. And those are tough situations where there are very bright people working on those questions at labs all across the country and around the world. But again, there are fewer of them oftentimes, and trying to find the right thing that works is tough.
That makes sense about the adults first. Yeah, for sure.
Yeah.
So I'm curious on the profit margin, so to speak, on cancer drugs, because, we get the bill, most insurance, thank goodness. But I'm like, does it really cost this many thousands to make it, like, what is it? It's just crazy to me.
Again, complicated question. Drug companies are out to make money, and they're equipped to make money more in the United States than anywhere else, because it's all smoke and mirrors, and I hate the system we practice in. There is a hospital that wants to make money from giving the drug, or whatever, a clinic or pharmacy or whoever. And then there is a producer or a drug company that wants to make money from the drug. And there is a middleman distributor that wants to get money from the drug. And there's an insurance company that wants to get their cut too. And there is all kinds of middlemen. And we have a system that's set up so that everybody here gets their little cut. If you go to another country, some of our cancer drugs are 1/10 the cost. And there's other reasons for that. To some extent, the profits made in the United States, to some extent, fund or subsidize further research. But they also are there to satisfy shareholders and make sure that everybody comes away with their little bit. So I'm biased against our system because it is unfair. And, sometimes I am tempted to say, move to Canada, move to France, move to some place where you're not going to get charged through the nose to get the treatment that you need. Send me a postcard.
Is that the reason you had said that the newer drugs are like in Seattle, Portland?
No.
Instead
So
of here?
the reason I said that is because they are complicated medicines that require a lot of infrastructure and a lot of monitoring, and the places that are equipped to give those medicines, the CAR T cells, for instance, are at bone marrow transplant centers. And the engineering of those cells and then giving those cells back is akin to a bone marrow transplant, where they're taking out stem cells and then giving you back stem cells, whether they're your own or some donors. And so that's why that happens.
So it's the infrastructure and probably the money also would be over there, that they could handle that type of thing. So you as an oncologist, if you could see that locally here, you couldn't really have the advantage of the newer drugs, would you then refer a patient to a more...
Yes, absolutely.
It's
less, I think, about the money and more about the infrastructure. And so large academic medical centers attached to universities are the ones that have the big bone marrow transplant units with the expertise required to run those. And so that's why we don't have them here. Maybe the Floyd Elson School of Medicine expands and we develop a large university
hospital system here, and one day we're able to do that, then that would be the condition probably to deliver CAR T cells more close to home. And at one point, they were doing autologous stem cell transplants in Spokane, and I hope to get back to that, soon here. And under that, if we were able to achieve that, I think that CAR T in Spokane and maybe one day in Coeur d'Alene would be an achievable goal. Because it would be great to do that here and not have to send people across the state to get those important treatments.
Just carrying on mine, I've been told so many times, I did a trial phase 1 in the Mayo Clinic. And they pretty much said it didn't work, sorry, see you, here's a box of clinics. And then I've heard go to Peru, go to Brazil, go to Germany, go here, go there. What do you think? Mayo Clinic said no problem. But I don't know if that's a standard answer that, not trying to this country or not.
I think that depends on what you're going for. I have a patient with metastatic pancreatic cancer. He's done some chemo, and it stopped working. And he's going to take his family down to Mexico, where he's going to get a high dose of vitamin C. And I can tell you with great confidence that's not going to do a lick of good for him. And he's going to spend a lot of money to do that. That's another thing we have a tremendous amount of research on. Vitamin C in cancer doesn't help. That's another one that people have a lot of faith in, unfortunately. It gets whispers and rumors. I know this guy who did it, and he does great, and he's cured, and he's fine. So if you're going to get mistletoe is another one for breast cancer. Over in Germany, it's a popular drug to give. It's just mistletoe extract. There's no good evidence that it works. But people will get on a plane and spend tens of thousands of dollars or more to go get those treatments. One thing I like to emphasize to my patients is that at the end of the day, they are their own decision makers. I make a recommendation. I offer a treatment or an alternative, or say, if you want, go to this place to get this thing, but you do what you think is best for you. And for some people, that is going to Peru to get ayahuasca in a tent. Now, I think what you might also be getting at is perhaps there are other medicines available that aren't available here. And I would say, do some research and figure out what is the evidence behind that drug. And if it's available there, why isn't some drug company making money off it here? Why hasn't it been approved here? If it turns out that everyone who takes it goes blind, but they live forever, great. And if that's okay with you, pursue it. If it turns out that it just didn't work, but it passed the lower standard of some other country's, FDA equivalent, I would say, please don't. And so I would figure out what it is that they're offering, and if they're offering it there, why aren't we offering it?
And is it available? The drugs that the world has, are you, U.S. and you, Dr. White, aware of them and what they do?
Yeah, so not all FDAs are the same, and not all countries have an FDA. And there are some countries that are approved. In Japan, for instance. 5-fluorouracil is a fantastic drug that we have here. There's an equivalent kind of drug that's much more effective in very certain circumstances called S1. And it's available in Japan. And it's not available here. And there have been lots of attempts to try and get it approved. And for various reasons, it hasn't been here in this country. And part of it is a genetic makeup. And it's less effective in white people than it is in East Asian people. But the fact of the matter is there are different medicines available in different places. Now, I will say that in the U.S., we have far more available to us than most other countries. And part of that is it's slower to adopt new medicines in other countries.
for instance, in the UK, they have something called NICE, the National Institute of Clinical Excellence, I think. And in order to get a drug, because they have a national health service, they don't want to just pay for every single expensive drug that gets approved or gets developed. They want to make sure that it's going to be effective for the cost they're going to pay for it. And so they want to make sure that the country can pay for that drug, and the people are going to benefit proportionally. And so we have more available to us because we'll just throw money at the problem. If you're looking for variety of treatments and the number of treatment options, probably greater here than anywhere else in the world.
And is that true for, sorry, I don't mean to hog the time, is that true for like MD Anderson, Mayo, Kootenai,
So
Wisconsin?
we
are they all the
have
same?
almost everything you can get at Mayo, you can get here. And the exceptions are the things that have to be at very specialized centers, and there aren't that many of them, and the list is shrinking. So one example is something called Pluvicto or Lutathera. These are two medicines that one treats something called neuroendocrine carcinoma, and the other treats prostate cancer, where you have a monoclonal antibody attached to a radiation drug. And it is delivering in that very targeted way a radiation molecule to destroy the cancer cell and not affect other cells around it. And we used to have to send people to specialized centers like Seattle and Portland, but now Inland Imaging can give those. And so they go to Spokane. And so the numbers of places where these medicines are available are increasing. We have clinical trials available to us, but we don't have all clinical trials available to us. And sometimes people say, should I go to Mayo or MD Anderson for a clinical trial? And did you live in Rochester?
I flew every 2 weeks from Spokane.
You are a brave woman.
Or I don't know.
And the reason I say that is because if it was a big phase 3 trial, and it had made it from phase 1 and phase 2, and we had a pretty good idea it might be helpful, then I'd say go for it. You don't have any other options here? Go for it. But for a phase 1 crapshoot, I wouldn't make that recommendation. Unless you had family over there, and you'd be staying with them and spending time with people that you love, and got something else out of the bargain. Because I would hate for you to go over there every 2 weeks for 6 months, and then the end result is, sorry, it didn't work, here's a box of tissues.
She's a platinum Delta traveler.
I am.
There you go. You got some serious miles out of that. So you did get something.
I did.
Take it or leave it. Yeah, so that's a tough thing. And how many other options are available to you? And what are your priorities? That's a very individual decision.
So you sitting in your office and you're meeting a new patient, let's say Karen, and you're meeting her and you're talking about looking at her specifics, then you would say, there is a study that is in clinical 2, over in X. So then would you then refer them over? It's not available here? That I've seen.
If you were interested in it and wanted to know more about it and talk about it with the people who are running the study,
right,
then I would make a referral.
So you have some type of networking that you can do to reach out there and
certainly
plunge in.
Oncology is a small world, and I trained in Boston. I'm still in contact with many of my colleagues there. Mm-hmm. We go to conferences and meet each other, and we know who's the expert in such and such a field, and we can reach out to them. And if they've got something cool, I go, hey, I've got this patient who might be a candidate for your clinical trial, and she'd like to come over. Then
she's platinum.
we can. Yeah, it's not going to cost her anything to fly. Then that would be something that we do.
Okay.
Doctor, I'd like to get your opinion on the radon thing.
Yeah, certainly. Well, radon is a known carcinogen, so we know that it can contribute to cancer. And that's a question I get asked an awful lot, is why me, doc? Like, what caused this thing? What led to this? And there are very few times we can point to X or point to Y or point to radon or say, this caused your cancer. Mesothelioma, we have a pretty good idea of what causes it. Guys walking around chomping on asbestos, knock it off. This long story short, and I'll go back to the way we treat these cancers. We always have cells in our body that are dividing. One cell dies and needs to be replaced, and so the cell divides and becomes a second identical cell. But sometimes that cell division process has an error in it. Copying the DNA doesn't happen perfectly every time. And sometimes that error can lead to a cell behaving differently if that error happens in a gene, in the P53 gene, which is responsible for identifying and correcting those errors that happen in cell division. And so that cell now has a mistake that causes it to misbehave, and it multiplies and becomes another cell, and is 2 more cells, thank you, and is 4 and then 8 more cells, and all of a sudden, you have a tumor. And my firm belief, because cell division and a mistake happens all the time, is that if you live long enough, you will develop some kind of cancer, especially in the world we live in. And so, yes, something like radon or cigarettes or benzene gas can cause a cancer, and we know that with certainty. But there are times when we just can't point to it. If you can mitigate it, though, it will decrease your risk, decreases your chances. So do your radon testing at your house. Don't smoke. Do your screening so that if we catch it real early so that it's more curable.
I wanted a couple other things too. One, thank you for being honest about drug costs and pharmacies and all that BS. Appreciate you stepping up with that.
I will say that we talk a lot about side effects. We talk about nausea and vomiting and low white blood cell count. We don't talk about the financial toxicity of cancer treatment. It's a real thing, and it causes tremendous stress for people and hardship. And I can say I have bankrupted people to treat their cancer, and it kills me. And it's not something that I like. I try to, and we have fantastic social workers and financial counselors to try and get patient assistance, to try and get free drug. And so we do that all the time, but man, it kills me to cause financial harm.
I think that's great. Thank you for being honest. I was at a conference in Chicago between 2 oncologists. They don't know who I am. They don't know nothing about me. And I hear this conversation, and this one doctor with a big old badge on said to the other doctor with a big old badge on, there will never be a cure for cancer because there's no profit in it.
I would disagree with that because there's profit in it for somebody.
For somebody.
And that company that comes up with it is going to get very rich, and it'll be, if it's a cure, a true proper cure, then it's a limited supply. They'll cure all the people they have to cure, but they're going to charge an arm and a leg for it. So to people who say that some government organization is holding a cure to cancer and keeping it back, I would say that is patently false, because somebody's going to find a way to monetize that. Because somebody's got shareholders that they want to impress.
Right. One other question for myself. I live in lung cancer world. I was stage 4 lung, as you all know. Is it still correct that lung cancer kills more people every year than all of those listed?
That is the biggest killer, even still. Yeah.
Even though, and I agree with you. Thank you for the honesty on the breast cancer funding, because I think I'm very jealous of the breast cancer world, because they've done an excellent job in marketing and getting all that money. Here's my take on the lung cancer. 9 out of 10 people think I had lung cancer because I smoked, which I never smoked one cigarette in my life. Mine was asbestos, as you know. But it's still true that lung kills
more than those.
And men and women.
That I believe is still true. Breast cancer is more common, but we also catch it earlier because of mammography. And so now we're implementing, for the majority of lung cancer patients who have smoked, lung cancer screening, if you meet certain requirements, having smoked more than a pack a day for 30 years, for instance, would qualify you for lung cancer screening.
Yeah.
So,
and it kills more people, but it's still less funded.
it's less visible and less sexy as a disease, and less, therefore, publicized.
You need to have Clint Eastwood ribbons.
Yeah.
So one thing when someone once said to me when they found out about my mom's cancer was, well, you should tell her to cut out sugar. And that would cure her. And I was like, I'm pretty sure a doctor would have covered that.
Again, yeah, that's false. That's remote.
Okay. We like her sugar.
There we go. So there is something to that. We know that high sugar diets in certain cancers, primarily breast and prostate, can decrease life expectancy in those conditions. That's not to say zero sugar means it will cure you, but adopting a low sugar diet appears to have a beneficial effect in breast and prostate cancer survival. So that's number one. Number two, though, is that that's not true of all cancers. Number three is that if you're losing weight, you've got nausea, vomiting, cancer's causing you to lose all kinds of weight, I would far rather you eat crummy calories than 0 calories. And that's something I say to my patients all the time. Either cancer or treatment is causing that. We know that there are worse outcomes for patients who are underweight. Cancer cachexia is a poor prognostic marker. We know you're in for trouble if you're losing a lot of weight. So I say poor calories or crummy calories. If that's ice cream, if that's all you can stomach, go for it. There you go. Yeah.
I was wondering if you had an opinion on hyperbaric oxygen therapy in oncology, if there's much research out there on that.
Hyperbaric oxygen has a role as treating symptoms and side effects and complications. And I would put it together with marijuana, for instance, where we have great evidence that it's helpful. It is great for nausea, great for appetite stimulation, great for sleep, pain. If you are feeling crummy from your cancer or your treatment, and you don't live in the state of Idaho because I can't legally recommend it, go for it. Travel across the state. I don't care. Give it a shot. See if it helps you. It's not going to help your cancer. There's no good evidence that it'll help your cancer. Now, hyperbaric oxygen. Sometimes there are problems from radiation, for instance, like radiation colitis or cystitis, where it's causing inflammation to the bowel, or we've got death of the jaw after radiation therapy to head and neck cancer, or you got a bone strengthening medicine that led to osteonecrosis of the jaw. There's fantastic evidence that it's helpful in those conditions, and it can alleviate pain, and it can help heal wounds. It's not going to cure cancer.
Could it make it grow more with the increased oxygen?
That is not something I'm aware of. But there's no evidence that I'm aware of either that it's helpful in treating cancers. But that's another common thing. Like, I'm going to go get my hyperbaric oxygen. Sorry, doctor, I don't want the thing that you have. I'm going to go try the other thing. And there are people in town who will say, yeah, we'll treat your stuff, whatever, with hyperbaric oxygen.
Thank you.
Yeah. And it can be helpful for all kinds of things. So there's usefulness to it. Yeah.
It'll help the symptoms of, but not the cancer.
Yeah. That we have good evidence to say.
If you ever meet a glioblastoma survivor, Adam's in.
You're how far out are you?
12 years?
Wow.
You are a 1%.
There you go.
We knew that.
That's awesome.
Glioblastoma? Mm-hmm. Huge. Jesus.
Right.
Wow, that's what my mom
You
died
get
from.
claps for that.
Wow, I
That's
would have
exciting.
cried.
Yeah.
Isn't that great?
I'm gonna go kiss you.
Easy
I don't care if you.
hard
Oh my gosh.
So there you go.
You don't need me. You had a fantastic surgeon.
Holy wow.
Yes, I did, Dr. Gans.
Dr.
He's
Gans.
retiring, which I'm not.
I know. What a jerk.
I know.
Selfish.
And Dr.
Yeah,
Kelly.
that's what I said.
And Dr. Kelly.
She's retiring too?
Oh,
sorry.
Oh, that's our rumor.
Because Sandy and I were talking, I'm bringing her back. If
Okay.
she's working, she's
Yes.
talking.
Dr. Kelly was my radiation oncologist, so.
Cool.
I'm gonna go get her. I had her pre-COVID. She's wonderful.
Yeah, absolutely.
Any other questions, guys? Doctor, thank you. That was
Thank you.
good.